Recording in progress.
Good morning, everybody. Thank you for joining us today. I'm going to give it just about 2 minutes longer as we still have people entering the wait room. So just give us a few minutes and we will get started. All right, we will go ahead and get started because I know it's Friday and some of you might be on lunch, so I want to really utilize our time the best we can. Today we have Dr. Goodwin with us, and if you aren't familiar with her, she is a great advocate, resource, part of the Down syndrome community. Not only is she a doctor, but she also has a son with Down syndrome, so she is a fellow mom. And today she's going to walk us through some really important information that I feel we will all benefit learning from. And then Dr. Goodwin, if you also don't mind and briefly kind of want to tell about your clinic too, that way we can make sure all the parents are aware of it. But I'm going to go ahead and turn it on over to you. I'm going to make you a host now.
Okay.
Okay, you should be the host now.
Let's see, it'll take me just a second to share my screen.
No problem.
Hmm. Let me try again. Okay, can y'all see that?
Yes.
Great. Okay. So I really appreciate you guys having me here, and thank you all for coming today. My name's Tara Goodwin. I'm an internal medicine doctor. I actually went to medical school at UNT Health Science Center there in Fort Worth. So, I know Fort Worth and appreciate Fort Worth. I spent a few years there. I moved to Dallas to do my residency in internal medicine. And from there, I worked at Baylor downtown as a hospitalist for many years until my second pregnancy with my son Patrick, who has Down syndrome, and he's now 13. I moved out of the hospital once I found out that he had Down syndrome, just to sort of try to make my love or my life love balance a little bit better with him and my other children. And I started working in what we call post-acute care. So I saw people in the nursing home and skilled nursing and memory care and assisted living and independent living. And I've been doing that really for the last 13 years. So I have sort of a special place in my heart for the geriatric community as well. In about, let's see, it was April of 2021 is when I opened the adult Down syndrome clinic here in Dallas, where I see exclusively adults with Down syndrome. And I had never really done clinic medicine before that. So that was kind of an endeavor and something new. But obviously, this is a community that means a lot to me, has a very special place in my heart. And so when I saw that a lot of the adults weren't really getting the attention and the care that they need, it really became just an important to me to sort of at least try to bridge that gap or provide some sort of care for them. So that's kind of what led to the clinic. So now I get asked to talk about aging and dementia and Down syndrome all together a lot, because these are, two of my passions, two of the populations that I take care of. But I recognize that this is sort of a daunting topic, and it can be a little depressing. And I in no way today want to depress you or make you feel hopeless. The purpose of this talk really is to kind of share information and keep us all educated and aware of aging and the aging process, and in particular, people with Down syndrome. And we're going to talk about dementia in the link there. But that's really so that we can move forward and act in a positive way to support our individuals as they age, and not really, my intent is not to make it, all doom and gloom. I think that there's some things that we do need to focus on that we need to be educated about. But overall, I hope that this is sort of an educational and something that we can think about moving forward to support them. So I have a lot of information to get through, so I'm going to go as quickly as I can through some of the easier things. I did put this disclaimer in. I think it's important that everybody knows that, I'm not providing any type of medical information here. I'm really just trying to give y'all as much knowledge and power so that you can go and see your medical professionals if, to have these conversations with them. And so our goals today are pretty lofty. I'm going to talk about strategies to promote healthy aging, and we'll move through that pretty quickly because I think that those are sort of known to everyone. We'll talk about the diagnoses that we see more commonly in people with Down syndrome and how they're different from the general population. I'm going to talk about life expectancy and the consequences in people with Down syndrome and how that's changed over the years. And then we'll sort of go through what Alzheimer's disease is, what the definition is, what it sort of looks like. And I know that most people on the call know what Down syndrome is, but I think it's important. I'm still going to kind of define it because I always think it's really important to keep everybody on the same page as we move through some of these complicated topics so that we understand what we're talking about. And then we'll talk about the prevalence of dementia, specifically in people with Down syndrome. And then most importantly, why does Alzheimer's disease occur in people with Down syndrome and why is it more common? And then lastly, we'll go through the symptoms and the diagnosis and the treatment that's available. So healthy aging. I think part of healthy aging is optimizing physical, mental, and social well-being. And I think for a long time, the medical community really focused on the physical. And it wasn't until recently that we've really started to understand the mental and social aspects, and kind of addressing all three of those is really what helps optimize health. And that's in every individual, not just people with Down syndrome. So I think that's always something we need to be focusing on and looking at, and promoting healthy lifestyles. When we talk about that, like, what do we mean? Well, nutrition, exercise, these are things that we're all sort of aware of, right? We need to be eating well. What we put in our body affects how we feel. We need to be exercising, staying mobile, especially as we age. Sleep is a very, very important one. That's where we get all of our restoration. So sleep is also very important. We'll talk specifically a little bit more about that in people with Down syndrome. Managing stress. I hate it when I hear, people in general, whether they're practitioners or not, talk about how people with Down syndrome don't really have stress. That's why their blood pressure is so low. And I always think that's the most ridiculous thing I've ever heard. Of course, people with Down syndrome have stress. They probably have more stress than we do. And they're having to deal with all of these difficult things in life and may not know how to manage that. And so as caregivers, it's kind of our responsibility to talk to them about stress, to teach them how to cope with stress and what kinds of things they can do to help manage that. And then social engagement becomes so important as they get older as well. When they're younger and they're interacting with their friends and their family, things are great. And then as they get older, siblings may be going off to college, maybe getting married, having families of their own, friends are leaving. All of these things can be big stressors in their lives and really affect their social engagement. And so it's really incumbent upon us to kind of keep that social engagement going and keep them active in the community so that they have that sense of worth and they're not feeling that depression that goes along with some of those losses. Lastly is routine medical care. This is something that I personally just believe in. I think the developmental form of care that we see through the pediatric population is really, really helpful and important when we're taking care of children. And I think that should also exist within the typical medical community, and also our individuals with Down syndrome. And so what I mean about this is I think everyone needs at least an annual visit to their healthcare provider. But we're going to talk a little bit more about the disparities and the gaps in healthcare that happen between the typical population and then individuals with Down syndrome. And we're not meeting their needs in a lot of ways. And so we need to make sure that we're following up and we're seeing our healthcare providers on a regular basis to get these specific topics addressed. So routine medical care is also part of healthy aging. This slide is a really important slide to me. We're going to spend a little time on this. It's not an exhaustive slide. It's just sort of an example. So this is part of the reason that I decided to do the adult Down syndrome clinic. And that's because when we look at the left-hand side of the slide, the arrow pointing down, those are things that are not very common in individuals with Down syndrome. So cancer and atherosclerotic heart disease are the #1 killers in America. So as an internist and in the clinic and even in the hospital, a lot of our focus is spent on diagnosing, preventing, and treating these problems. And so what happens is our individuals with Down syndrome go to the clinic, and these are the problems that a lot of them, are they're looking for these problems and managing these problems in our individuals with Down syndrome. But these aren't really problems for our individuals. They get congenital heart disease, but atherosclerotic heart disease is completely different than congenital heart disease. I always like to point that out. And so, doing screening tests for cancer and doing stress tests and managing all of the things related to these types of diagnoses may not be as important as some of the things that we see on the right-hand side of the screen. So the things that are more common in our individuals with Down syndrome are things like obstructive sleep apnea. That's something that we know is very, very common in the Down syndrome population, and it's not being evaluated appropriately. In fact, I've noticed in my clinic that even in the pediatric population, they're not getting their sleep studies the way that it's recommended. So it's really, really important to pay attention to the things that they are at risk for. So things like sleep apnea. I put leukemia up here. The cancers that are more prevalent in people with Down syndrome are leukemia, lymphoma, melanoma, and testicular cancer is the one solid tumor cancer that we see more commonly in the Down syndrome population. So I recommend that all of my adult males have a testicular exam by a healthcare professional at least once a year as a screening for testicular cancer. The other thing that's way more common in the Down syndrome population is autoimmune diseases. And this includes type 1 diabetes, celiac disease, the Hashimoto's thyroiditis that causes hypothyroidism, vitiligo, alopecia, psoriasis, rheumatoid arthritis. All of these things kind of fall under an autoimmune disorder. And so it's very, very common in the Down syndrome population for reasons we don't have time to get into, but it needs to be evaluated and looked at more so than in the typical population. And then what we're going to spend some time talking on today is the Alzheimer's disease, because we do know that that's more common in the Down syndrome population as well. So I think understanding that the differences and that what these needs are is important for prevention in our individuals as they age. This next slide is from a study that was done where it showed that there were frequently unrecognized or poorly managed conditions in the IDD population. And in the IDD population, Down syndrome is the majority of that population. And so these are all of the things that they found that were either not being recognized at all or were recognized but not being managed well. And this is the gap that I'm kind of talking about when I say that there's just a healthcare gap between individuals with IDD and then the typical population. And so vision and hearing impairments, according to the adult practice guidelines, we should be doing vision and hearing exams every 2 years on our individuals with Down syndrome to look for any changes, especially as they age. Obesity, epilepsy, which is seizures, skin conditions are very, very common in Down syndrome and not always managed appropriately. Dental pathology, it's very important that they be seeing their dentist every 6 months. This can lead to pain, which can cause behavior problems. It can lead to pain where they're not eating and they start having a lot of weight loss. And so we want to kind of know those things as soon as we can so we can address them. Behavior and mental health problems are huge as they start to get older. The adult practice guidelines recommend that we monitor behavior and mental health at least annually. And so you need to be talking to your care provider at least once a year about changes or things that are happening and how those things can be addressed and managed. Gastrointestinal conditions, the most common are going to be constipation and then celiac disease. Celiac disease is way more common in individuals with Down syndrome than in the typical population, about 6 times more. So any type of gastrointestinal problems and even behavioral changes, we need to be looking for things like celiac. Polypharmacy just means a lot of medications. So a lot of times what happens is, even in the typical population, people just get a pill, get a pill, get a pill. And after a while, you're on so many medications, you're not sure what they're even for anymore. And so every time you go to the doctor, you should be talking about what medicines you're taking and whether or not you need to continue to take those medicines, because if they're not really needed, you shouldn't be taking them. Obstructive sleep apnea. I'm going to touch on this just a little bit again, because this is a real big one for me. I'll say this, there's a recent study done that showed that 66% of people with Down syndrome have moderate to severe sleep apnea. And 53% of those that were diagnosed had no symptoms to report. So to me, that's just striking. That to me says that the most common symptom of obstructive sleep apnea is no symptom at all in people with Down syndrome specifically. 66%, that's more than congenital heart disease, which is about 50% of our individuals. So this is a really prevalent problem that we're missing. And it can cause a lot of the symptoms that we see even with Alzheimer's disease. So when you're not getting enough oxygen when you're sleeping, when you're not getting restful sleep, when your carbon dioxide levels get high because you have you may have sleep apnea, those are all things that are going to impact their cognition and their ability to go about their day-to-day activities. And with obstructive sleep apnea, it's not an easy treatment, but it is a treatable problem. And so I just think it's really, really important, knowing how common it is in people with Down syndrome, to really, really be evaluating that and treating that where we can to make a big impact on their day-to-day lives. And then Alzheimer's disease, and that we're going to spend a lot of time talking about as we go through these slides. So these are 2 graphs of life expectancy. The one on the left is life expectancy in people with Down syndrome. And the one on the right is for the general population. And so you can see how these cover about the same time span, and you can see that both have improved. But the life expectancy of people with Down syndrome has had a dramatic improvement over the last 100 years. In 1900, the average life expectancy of someone with Down syndrome was about 9 years of age, and that was ongoing for many, many decades. But today, the average life expectancy of someone with Down syndrome is about 60 years old. So we've made some really, really great progress. And if we want to talk about why that is, I think we can say there's improved healthcare overall, right? The whole population has benefited from just improved healthcare in general. But in particular for people with Down syndrome, it's been the availability of treatments, the treatments made available to them. So they were starting to get heart surgery for congenital heart disease, and that improved their life expectancy. They were able to be treated with antibiotics, which may not have been a treatment really offered to them when they were institutionalized. There's also been refined social acceptability. So they've come out of the institutions and are now living in a family home where they have access to education and employment, and they're supported by their families and their community. And so there's improved advocacy for those who love and support them. I think this is important because if our goal for those with IDD or with Down syndrome is to promote their health and improve their quality of life and, continue to, extend their life expectancy even more, we need to focus on the things that we know have worked in the past, and that's access to healthcare or routine medical visits and encouraging social interactions with everyone around them. And then continuing that advocacy, just advocate for this population. Now, within this improved life expectancy, there are consequences that go with that. And so as individuals are aging, we're starting to see more disorders that are associated with old age. So we see mental, there's more depression and anxiety related to the ongoing stressors as they age and whether or not they're able to cope with those. We're seeing physical changes. There's more osteoarthritis and vision and hearing and sensory changes. And then, of course, we're seeing dementia as well. We're also seeing that as parents, we're aging and getting older, and it's getting to the point where sometimes we're not able to take care of them because we're not even able to take care of ourselves. I mean, as we're aging too, and that's going to happen. And so I don't have the answers to all of these consequences, but I think that they're important topics to kind of bring up and think about, because these are things that as our population, our Down syndrome population starts to age, we need to start paying attention to what are we going to do when we're not around as parents. And so finding caregivers for them, whether it's a sibling or someone else, and trying to make that transition as easy as possible so that they kind of have the history and know about that person. There's lots of residential options for the geriatric community, but there's not a whole lot that are suitable and sort of made for individuals with IDD. I can see that that's changing and improving, but a lot of those are still sort of private care and very, very expensive. And so we really need more options. And then end of life planning. I don't think anybody, wants to talk about end of life planning, but it is so incredibly important to have that preparation. And I don't mean for the parents, I mean for the individual with Down syndrome. As parents, I think, I like to say we're the experts in our individual. And so it's really important that we be a part of that discussion, I think, in talking to our individual and also whoever is going to kind of take on that responsibility after we may be gone. And just having this very difficult but open and honest conversation about what the end of life looks like and what we should be preparing for. So I don't have the answers to all of that, but I do think that those are important things to think about. Dementia is an umbrella term. So there's more than one type of dementia. But today we're really going to focus on Alzheimer's disease. It's the most common type of dementia that we see, and it's the one that's more prevalent in people with Down syndrome. So I just kind of wanted to make everybody aware that while there are different types of dementia, really today, for our purposes, we're really just talking about Alzheimer's disease. And so here's our definition of Alzheimer's disease from the NIH: an irreversible brain disorder that slowly destroys memory and thinking skills and eventually the ability to carry out the simplest of tasks. And again, this is the most common form of dementia, Alzheimer's disease, in the United States. And I love to use visuals because I think you can get so much information out of just a picture. So I put these up here. On the left, we're looking at a gross specimen of a brain. And you can see what the healthy brain is very robust and clean and vibrant. And the severe Alzheimer's brain is more shrunken and atrophied and just doesn't look nearly as healthy. And when we look at the cartoon schematic on the right, we can see that on this left side portion. This is the normal neurons. I thought it would be easier as a cartoon to see. And on the right-hand side, you can see the pathology that's happening in the neurons. So inside, it's hard to see, there's what's called neurofibrillary tangles. And then outside in the parenchyma next to the nerve cells are these amyloid plaques that develop. And these neurofibrillary tangles and the amyloid plaques, this is what leads to the neuronal cell loss, or the loss of neurons, that kind of causes the gross changes that we're seeing here on the left with the severe Alzheimer's brain. Okay, so what is Down syndrome? I know everyone on this call knows this, but I put up this karyotype and we're going to go through it very, very quickly. Excuse me. So there are 23 sets of chromosomes. When we look at the top left-hand corner, we can see that there's two chromosome one. One is from the mother, one is from the father. As we march through and we get down to chromosome 21, we see this extra third copy of chromosome 21. This is what we call trisomy 21. This extra genetic material is responsible for the physical characteristics that we see in Down syndrome, and also the reason that they have, different medical needs. It's all because of this extra genetic material. So as you march down, you can see there's an X and a Y. So this is a karyotype for a male with Down syndrome. So the prevalence of dementia and Down syndrome, this is the slide that I hate the most because it's a very negative sort of slide, but I think that it's important to have an honest discussion about the prevalence and what we're dealing with in order to sort of move forward and make an impact. The study in 2019 showed that at the age of less than 40, the prevalence of dementia in someone with Down syndrome was about 4%. So this is really, really important because it's pretty rare to have a diagnosis of Alzheimer's disease in someone with Down syndrome before the age of 40. And I get a lot of referrals of people in their 20s where their doctor is very concerned that they have Alzheimer's disease. And so it's pretty encouraging to have somebody come in and I get to say, the chances of this being Alzheimer's disease are very rare. It's most likely something else, some other process going on that we just need to, kind of delineate and figure out what it is. So if any of you are joining today and you have someone who's less than the age of 40 and you're worried that they have Alzheimer's disease, I'm here to tell you that that's exceedingly rare. It doesn't mean that they might not eventually get it, but to have it before the age of 40 is pretty rare, and it's most likely something else that's leading to their symptoms. Now, ages 40 to 54, we see a dramatic increase. About 40% of people with Down syndrome are having a diagnosis or signs and symptoms of Alzheimer's dementia. And that increases even more after the age of 55. So then they're about 61%. To put this in perspective for you compared to the typical population, at the age of 65 and older, the risk or prevalence of Alzheimer's disease is about 10%. So this is a dramatic increase in prevalence in our population. The lifetime risk is 90%, and that's a pretty daunting number, but I like to compare that kind of to the general population. I mean, as people get older, their risk of dementia and those symptoms increase. So, there's an adage among the medical community that, it's an if or when. It's, dementia is going to come at some point. If you live to be 140 years old, there's a chance you're going to get it. So as we progress into our, age, the risk does tend to increase. The typical survival time following a dementia diagnosis in Down syndrome is about 4 years. That compared to the general population, it's about 10 years from diagnosis until mortality. And so 4 years is significantly shorter. I don't know that anybody can say for sure why that is. I think it's postulated and speculated that it has to do with the degree of cognitive impairment at the diagnosis. We've seen that in the general population, the more cognitively impaired the individual is at the onset of diagnosis, the shorter that time period of survival is. So that may have something to do with it. So why is Alzheimer's disease more common in individuals with Down syndrome? Well, it goes back to the trisomy 21 that we were talking about before. So there's a gene on chromosome 21. It's called the APP gene, and it stands for the amyloid precursor protein. And this gene has been shown to be crucial in developing Alzheimer's disease. And so because people with Down syndrome have 3 copies of chromosome 21, that's why they have a higher risk of developing Alzheimer's disease. It's because of this increased genetic material that they're carrying. So what is the APP gene and why is it important? Well, it codes for what we call the amyloid precursor protein. And this amyloid precursor protein makes beta amyloid. And then the beta amyloid becomes these amyloid plaques. And those were in the cartoon schematic that we saw earlier that causes Alzheimer's disease. And so the fact that there's just more amyloid plaque being developed because they have more genetic material is what leads to the increased prevalence and risk of Alzheimer's disease in individuals with Down syndrome. The symptoms of Alzheimer's disease and Down syndrome are very similar to the general population. They get memory impairment and loss of skills that they could previously do. They can have a gait disturbance and weight loss. Dysphagia is difficulty swallowing. That's very common. Incontinence of urine, losing urine, and then insomnia or even sundowning. A couple of the bigger changes in people with Down syndrome is that 77% of them will develop seizures with their Alzheimer's disease. And that's compared to the general population where it's about 2 to 25%. The other thing is that a lot of times the seizures may be the presenting symptom. And I'm talking about new onset seizures. So in someone who's never had a seizure before and now they're 45 and they have their first seizure and they're also having some of these other changes, that's a very, very concerning description of somebody who may have Alzheimer's disease if they have Down syndrome. The other thing that we see is big personality and psychological and behavioral changes in individuals with Down syndrome. In the typical population, we do see these changes, but it's much more advanced in the disease, whereas a lot of times the personality or psychological changes can be the presenting symptom in somebody with Down syndrome. Now, making the diagnosis is very difficult. There's no blood test, there's no x-ray that someone does and says this person has Alzheimer's disease. There are imaging abnormalities that we can see, but the diagnosis for Alzheimer's disease remains what we call a clinical diagnosis. It's not really, there's not a specific test that we can do. So we kind of take a bunch of information in order to make the diagnosis. Now, in the typical population, we do testing or screening tests that's called a mini mental status exam, or there's a slums test. And these are done by the individual, and we kind of monitor that cognitive function over time to see if there's changes. But it's very difficult to do that same thing in someone with Down syndrome because these tests are difficult for them to do on their best day. They're cognitive tests that are made for the general population. So the National Task Group came out with an early detection screening test for individuals with IDD, and that is a caregiver-driven test. So it's done by the parent, by the sibling, by whoever the caregiver may be, about the individual with Down syndrome. And the adult practice guidelines recommend that this be done on an annual basis in people starting at age 40 with Down syndrome. And what it does is it sort of looks at cognition, behavior, mood and personality, memory, sleep, activities of daily living. And you sort of just keep a tab on all of those different areas. And if there's dramatic changes or changes that are happening, it's a great test to bring into your practitioner and say, look, there's been this huge change in their ADLs or in their sleep. Can we talk about what that might mean? And so it's really kind of just for caregivers to have. Now, a lot of caregivers may not need this, but I think it's helpful to sort of keep all of those different areas in the same little document and kind of keep track of it, because there's a lot going on in all of our lives. And sometimes we're not seeing something even when it's right in front of us. So this is the one sort of screening test that we have for individuals with IDD or Down syndrome. When we're making the diagnosis, one of the most important things, and I alluded to this earlier, is to make sure that we've kind of ruled out everything else. So making the diagnosis of dementia, it's a diagnosis of exclusion. So there are other things that can cause symptoms that are similar to the symptoms that we see with dementia. And we really want to make sure it's not one of those things. And we'll talk a little bit about what some of those things are in the next slide. But making sure that it's not something that we can easily modify or treat or manage becomes very, very important before we just make a diagnosis of dementia. And then I always like to put in this understanding normal features of cognitive aging, like self-talk. Self-talk is something that's very common in the Down syndrome community. I always think it's important to say that and talk about that, because I've seen a lot of individuals who are on antipsychotic medications with the goal to eliminate their self-talk. And that drives me insane as a parent, but also as a physician. Self-talk is important to our individuals with Down syndrome. It allows them to work through some of the conflicts that they may be dealing with in their day-to-day lives. It allows them to just sort of, entertain themselves sometimes, but it's never really hurting anybody or hurting themselves to do it. I've seen it in the geriatric population as well. It's always a big red flag among staff members. I get calls on how are we going to fix this? And the bottom line for me is that if someone is participating in a behavior that's not hurting them and not hurting anyone else around them, I say you support it and, redirect or intervene, but there's no reason to medicate for something like that. And then, if we've done the differential diagnosis and we've sort of excluded everything and we're looking at the screening test and it seems that it's not really, there's some changes, then I think getting a neurologic evaluation and further testing is a good idea. So when we're talking about a differential diagnosis, this is just, again, a short list of things that we need to kind of think about. We need to be looking for B12 deficiency. There's something that's super easy to fix if we find it. Can it cause cognitive problems or gait disturbances? It absolutely can. So we can see some of the symptoms associated with that, and that's something we can easily fix. We've talked about sleep apnea already, so I won't belabor that anymore. But diagnosing and treating sleep apnea can be very important and can really, it could be a mimicker of Alzheimer's disease. Hypothyroidism, it's recommended that all people with Down syndrome at least get their thyroid test annually. Those who have hypothyroidism, it's usually even more often. Depression is a big one. Depression, it can co-occur with Alzheimer's disease, but it's really, really important to address depression and possibly treat it with medications or cognitive behavioral therapy, because sometimes when we treat the depression, a lot of those behavior changes or things that we're worried about that may be causing what we think is causing Alzheimer's disease may improve. Cataracts, vision loss, hearing loss. We talked about, routine screenings every 2 years for our adults so that we can catch those things and correct them if we need to. We've talked about celiac disease and, again, polypharmacy. All of these things just need to be evaluated and make sure that we can cross some of these things off of the list to determine whether or not we're truly getting to a diagnosis of Alzheimer's disease or not. And again, this isn't an exhaustive list. It's just to give you an example. We can see sudden change as well, and we have to pay attention to that. That can kind of show signs of what people will worry about being Alzheimer's disease. Stroke, while it's not very common in people with Down syndrome, it's something to be, considered. Infection, maybe a urinary tract infection or pneumonia, those can cause changes. Metabolic problems, electrolyte problems, dehydration, insomnia. Maybe they're just not sleeping, and after days or nights and nights of not sleeping, we're starting to see some of the cognitive changes. Pain is another really important one. I find that people with Down syndrome don't really complain of pain a whole lot. And so sometimes it's really, really difficult to get that history out of them and figure out, if they're in pain. Sometimes we just have to treat them for pain just to see if anything improves. So the medical treatment options for Alzheimer's disease are awful. There's just not a lot of great options. I've listed them here: cholinesterase inhibitors, NMDA receptor antagonists like memantine or Namenda, and then the newer drugs, the antibodies that are targeting beta amyloid. All of these are out on the market now. None of them have been approved for individuals with Down syndrome. So the use of these medications is typically what we call off-label, and they are being used in general, and I'll show you the next slide. It will kind of elucidate this. In general, a lot of people don't continue the medications because the side effects seem to be worse than the treatment. Some of them do take the medications, and overall, we've just not seen a huge impact from any of the older medicines. The antibodies we'll still have to kind of figure out if there's anything real meaningful there. I did put an Alzheimer's disease vaccine on here, and the reason for that is because there are studies going on that include an Alzheimer's vaccine. And there's a doctor, Dr. Brendan Kelly at UT Southwestern, who is looking to maybe start a study on individuals with Down syndrome using this vaccine to prevent amyloid buildup in the brain that causes Alzheimer's disease. And so he had reached out to me and asked if I thought that the Down syndrome community would be open to participating in a study like this. And I'm sorry to say that I threw everyone here under the bus and said, absolutely, we would, as a community, we would love to participate. But honestly, I think on a national level, the Down syndrome community has always been very open about participating in studies like this, because we want to know what's going to work for our population specifically. So I am happy to share that information as I get it, if he decides to do this study, so that it can be available to your community in Fort Worth as well. So the real impact of treatment for Alzheimer's disease has to do with treatment of symptoms, which includes treating depression and anxiety and agitation and insomnia, and then anti-seizure medications if they're needed. And then we'll talk about some of the environmental supports that are also part of the treatment process for people with Alzheimer's disease. This next slide, if I can get it to come up, is basically a Cochrane review that did look at medications in people with Down syndrome using some of the Alzheimer's disease medications. These weren't huge studies, but there were several of them that were reviewed. They used donepezil in 4 studies. That's Aricept, or memantine is Namenda. And then they also used some of the other sort of off-label treatments. Simvastatin is anti-cholesterol medication, and then they looked at antioxidants. But basically, the overall summation was that the effectiveness was very low, and really no better than placebo. And I'll tell you, in the general population, this is my feeling as well. Even in the general population, I rarely see anybody on these medications have any significant clinical improvement. In my experience, I've not personally used the antibody treatment on anyone that's a patient of mine with dementia. just because of the risk profile. Most people are not really interested in participating because of that. And then the non-medical treatment options, this is really where we can have a big impact to support our individuals with Down syndrome. And basically what it comes down to is we've just got to try to see the world through their eyes and accommodate them where we can. Just environmental supports, big contrasting colors and adequate lighting, because they can have some sensory deficits with both hearing and vision. Removing mirrors and rugs. Mirrors are so they don't always recognize themselves when they see themselves in the mirror, and that can be very troubling and agitating. Using adaptive equipment so that they're ambulating and able to get around and able to do the things that they, could previously do, but they may just require some equipment. And so having really great support from physical therapists and speech therapists and occupational therapists to really help determine what their accommodations and needs are can be helpful. And then I put this in here. I think having a life story or even an orientation book in someone who has Down syndrome and has Alzheimer's disease can actually be helpful for a couple of reasons. I think it can help the individual be reoriented to their life if they're having problems remembering, or maybe they're getting agitated because they're in an environment they don't really recognize anymore. And so seeing things and having things around or looking at things in a book or however someone wants to do it, to just sort of reorient them and calm them down and sort of support them with the things that they love. I also think it can be beneficial for caregivers who may not be as familiar with our individual, so that they understand kind of where they came from, who they are, who they used to be, what are things that they like or dislike. I think books like this can be really, really helpful. I totally just made up all of these little topics, just sort of as an idea of what I would think a good book would sort of cover. But I think that this is always very helpful in both of those aspects. And I think using pictures and visuals in anything we do with people with Down syndrome is always very helpful to them in communicating and comforting. And so I'm finally done talking, and I'm anxious to take any questions anybody may have. I know this has been a lot of information, but I wanted to give y'all as much as I possibly could. And so thank you for having me.
Leah, do you have a question?
I do. I think I have like two.
Okay.
First, Dr. Goodman, thank you so much. This was good information to have. I will say I'm the sister of a brother with Down syndrome. We're both in our 40s. And unfortunately, with my type A personality, of course, I like to plan.
I understand that totally.
Because I do understand, like, one day I'm going to be his caregiver. I want to be his caregiver. Like, I'm looking forward to that time with him. And like you use the word, you see adults with Down syndrome, considering their life expectancy is 60. My brother sees a typical, GP doctor, but she obviously doesn't know a lot about Down syndrome. She's kind of learning with us as we grow. Like, is there a point where we need to transition him to a specialty doctor, knowing he's getting older? Are we good staying with her? And then, man, can you open an office in Fort Worth? Because that would be great.
I've already tried that.
Yeah. So here's what I like to tell caregivers and parents, because I'm not an expert in Down syndrome. Finding an expert is incredibly difficult across the nation. And so what I always tell people is, you are the expert. You're the expert in your person with Down syndrome. what you're looking for in a healthcare provider is someone who will listen and learn with you. Finding out information like some of the information that I've presented today is not difficult. It just requires a little thought and, looking into things.
Uh-huh.
So I always tell people, I think the most important thing about a healthcare provider is having someone who will listen and who will work with you. And that's a good relationship. And so you don't necessarily have to have a specialist in Down syndrome. That's going to be exceedingly hard to do. But I think just having that open communication is really, really important. There is a group, it's called the Down Syndrome Medical Interest Group. And they are actively recruiting physicians from everywhere to join their group and learn more about individuals with Down syndrome. So I always tell, caregivers, share that information with your healthcare provider. The membership is like $100 for the year, and they have all the access to the information that they need. In addition to access to experts in Down syndrome through that medical interest group. That is certainly how I kind of started this whole process, was joining that group and working with them. And they're always anxious to help. So in short, I think staying with your practitioner, as long as, she's working with you, is perfectly fine. And then I'm always happy to talk to other doctors or, provide information. I don't know if I've shared my email address with you or not, Elise, or you have my email address. Yes, because y'all, that's how people contact me typically, is through my email. And so I'm always happy to help where I can.
Okay, great. Thanks. She's been great. I mean, my brother's been seeing her since we were teenagers, and here we are in our 40s. She's still our doctor, and so far it's all been good. And I understand that it's a tricky thing to try to find a doctor for. So, okay, that's just good to have. Thank you.
And then it looks like we have some questions in the chat.
Okay.
We have, do you recommend any supplements that seem to help with the prevention of Alzheimer's or for general health?
So I always tell my families when they come in to see me, no. The answer is no. In general, I can't, as a physician, make a recommendation for any type of specific supplement that is going to help with any of this. Now, if I take my doctor hat off and I put on my, mom hat, I will tell you that I do supplements for Patrick. So I do give him B12 and folate, and I give him vitamin D. And with vitamin D, you have to be careful because you do need to check a level. It's fat soluble, so it could get toxic. So you need to know that. I'm not opposed to supplements. In general, my feeling is that, if they're not hurting the individual, then I think it's fine. But as a physician, I can't technically recommend. I don't know of anything I could recommend and that's very impactful.
And then do you see the risks of leukemia increase or decrease as they age?
So the risk of leukemia is interesting. If they had leukemia as a child, their risk of leukemia having a reoccurrence as an adult is much higher. But in general, it's something we just watch for. I've personally, in my Down syndrome practice, I have a few patients who had it as children, but I don't have any patients who have it right now. I have not diagnosed that as adults. So in general, I can't speak specifically to Down syndrome, but in general, the population, will leukemia increase with age? It can, especially the CLL, the chronic type, is very common with increasing age. And so I would guess that that's the same with Down syndrome, but the real risk is whether or not they have a history of that.
And then what are the days and hours of your clinic in Dallas?
So right now, my intake for new patients is on Tuesdays and Thursdays, and I work from about 9 to 2, because as a mom, I have to be available to take my kids to school and pick them up. So those are sort of my hours. What I tell my families is, even though I'm technically, my clinic hours are Tuesdays and Thursdays, I can see, people via televisits or Zoom. I can, everyone who comes to see me gets my email address. And so it's easy to kind of communicate via email. And if I need to get somebody in on a Monday, Wednesday, or Friday, we can figure something like that out. But my set clinic hours are those Tuesdays and Thursdays.
So would it be best to call to make an appointment if they want to come see you? Okay.
Yeah, even if you emailed me, I would have to give you the phone number to call, because I can manage a lot of things, but that starts to get out of my control.
Understandable. Okay, and then do our adults continue to develop health problems as they age, or is there an age when it is unlikely to develop new autoimmune diseases?
No, they're always at risk for autoimmune diseases. And I think the hard part about autoimmune diseases and sleep apnea is that it's not a one test and done sort of situation. It's not black and white. It's not 0 or 100. It can develop at any time across their lifespan. So for instance, my son, we did his sleep study. I think he was 6 years old when we got it, and it was normal. And then, for reasons I won't get into here, we ended up repeating the test this year, and to my shock, he has severe sleep apnea. So I think, things can change over time, but those risks are always there. And so we kind of just have to be vigilant about, if somebody tests negative for celiac at some point in their life, but they really start to develop more symptoms later, we need to look again. We need to, anytime we're concerned, we got to just keep looking.
And does a family history of Alzheimer's increase the Down syndrome chances?
It may. Mm-hmm.
Okay. Have you learned of any fitness programs for people specifically with Down syndrome in the Fort Worth area?
Well, now that I was going to say, I don't know if these people are in Fort Worth, but I don't think they are. There is a program here in the Metroplex area. It's not really in Dallas, called Special Strong.
Yes.
And so I know that they're trying to kind of broaden their reach.
There's no way to get it.
But
we have Special Strong in Fort Worth.
you do?
Yes, we do. They operate right now out of the Bedford Y, and they have reached out to some others, and they will come to your home as well. I met with him, talked to him last week. But there are, so that it is in work, and there is one at Bedford. And if you contact the guy, I have his card somewhere, they will also send people to your home. So not as accessible as you would like, but it's there, and they're looking actively to grow it.
Yeah.
Well, and just
I
a
think it's a
side
great
note,
program.
DSP&T is partnering with him in 2024 to bring those classes to our actual office. So watch for that information. There'll probably be weekday mornings or afternoon classes, but we are working with him to bring those to our office.
There's also a program through the NDSS. I think it's called 321, and it's a fitness program. And I think you send, I can't remember specifically. This came up at a meeting we were at. I think it's like $60, and they send you all of the equipment and then a program, a fitness program. But I will say this, I think, going back to that promoting healthy lifestyles and looking at all of those different areas, one of the things I think sometimes we get in our head that we have to, like, exercise should be like a specific routine. I think it's important. I tell my families, when we're going over exercise in the clinic is, dancing is exercise. And I've never met a person with Down syndrome who told me they hated dancing. Like they love to dance. And so finding something that they love to do that's also a fitness activity is huge. And they can do it multiple times a day or multiple times a week. But I think even things like, parking far away and having them walk further and just those little things that we can incorporate into our day-to-day stuff rather than making it such a burden to like, how am I going to find time to do this, 30 minutes every day? I think taking small, simple steps, and kind of building on that works best for people to be successful.
Okay. Do you know anything about the Down syndrome clinic at UTS Southwestern?
So that's the Children's Down Syndrome Clinic. It's a consult clinic, and it is run by developmental pediatricians. I know them. It's a great clinic. And so they provide care for the pediatric population, and then they're a big referral source for me as well. They refer their patients to transition into the adult clinic from there.
Awesome. Okay. And then what is your experience with skin issues / boils?
I've never met a person with Down syndrome that doesn't have some form of skin problem. Sometimes it's just dry skin. It's very, very prevalent. They are at high risk of getting what we call hidradenitis suppurativa, and that can be incredibly difficult to treat. It can require multiple rounds of antibiotics, and it can sometimes require surgical intervention. So what I usually tell
I'm gonna leave.
I lost you.
I think you're good.
What I typically tell my families is there's a over-the-counter medication called Hibiclens. It's the pink soap. You can find it on Amazon. You can find it at any pharmacy. It's kind of a thin soap, but it's an antibacterial soap that kind of just gets all the bacteria off the skin. We use it a lot for pre-surgery for people to wash with before they're going to go into surgery, just to kill all the bacteria on the skin. And it's that bacteria that's kind of burrowing in there that's leading to a lot of the folliculitis and pimples and boils and things that we're seeing. And so I usually tell people to start with that and do that where they wash just normally, and then right before they're going to get out of the shower, kind of put this film either all over or all those areas like, the groin and under the arms and any areas that you're worried about. And then leave it on for just, a few seconds. Doesn't take very long. And then you can wash it off and get out. And then drying off for people with Down syndrome, very, very important to prevent fungal infections. And then beyond the Hibiclens, there's benzoyl peroxide washes, or Panoxyl, or Dr. Song's is another brand name that you can also use for kind of flare-ups or on a regular basis, even as a preventative. That solution it's a bleach, so it'll stain your towels. I always tell my families, be aware of that. If you're going to use the benzoyl peroxide, make sure you're using a white towel to dry off. But that's where I usually start. And then dermatologists are pretty good about, managing when things get out of control. That's what I typically do is start to involve a dermatologist to help manage these.
And you said the Hibiclens soap, right? I'm probably saying that wrong.
Hibiclens, Hibiclens.
Okay, perfect. And then Cynthia, did you have a question? I saw you had turned your camera on, so I thought you might have a.
I just had a comment. Thank you so much for this presentation. It's been very helpful. I actually went to see Dr. Kelly because my mom has early symptoms of dementia. And while I was there, mentioned that I had my brother. So I care for my brother. He lives with me, who has Down syndrome. And he mentioned that some of the things, just like you were saying, that is very common, the sleep apnea. and that it's so hard to get the Downs kids or people to get on a CPAP machine when they're older and already experiencing dementia, that it really is very difficult for them to get used to that. So he actually was the one who mentioned to me, go get him tested, which my brother is 38 and definitely needed a CPAP machine. And so I just wanted to share that information with everyone as well, that kind of when they already get the dementia, it may be a little bit more difficult to get these sleep apnea machines, and it helps with memory, right? And helps your brain. So
it's definitely the older they get, the more difficult it's going to be, because they're so set in their routines, right? And that hasn't been a part of their routine. And so it's very, very challenging. I mean, I'm speaking from personal experience. I'm sleep deprived because it's so challenging. But I think I read, do you recommend a sleep study for our population, even without symptoms? What are the consequences of untreated sleep apnea? Okay, the answer to that is absolutely yes. The consequences of untreated sleep apnea are, I could go on and on and on. I think the most impactful in our population, I mean, I can give you lots of examples, but is cognition. They have a change in cognition. They're going to have behavioral disturbances and behavioral problems. One of the very first patients that I saw in my clinic came to me after being in the hospital for severe agitation. And it was really it's been sort of just a sad story to be a part of. But he was treated with antipsychotics to the point where he couldn't even function anymore. I mean, this poor child had been in school and now couldn't even walk, couldn't, function in school by any means. We ended up getting him off of the antipsychotics, and through a very long process, it turns out he has the worst sleep apnea I've ever seen, and no symptoms outside of agitation and behavioral change. And so it's a challenge, but we're just at the point where we're starting him on the CPAP machine. To give you an idea, they have a apnea hypoxia index, and if it's greater than 10, that's typically diagnostic of severe sleep apnea. So that's basically the number of times that they're not breathing when they're sleeping, and his was 87. So I've never seen a number that high. And again, hardly any symptoms. My son, I did the test because I wanted to kind of show that he didn't have sleep apnea. And keep in mind, I'm a practitioner. When we went to do the sleep study, he slept all night. He did great. I walked out of there. I told my husband, he's fine. He's fine. Comes back, severe sleep apnea. I was shocked. I was completely shocked. And so I can't really tell my patients even, what to look for, because I kind of joke and say the number one symptom is no symptom at all. It's nothing. So what I would typically tell people, we're going to have recommendations that come out, I'm hoping in 2024, that are in addition to the adult practice guidelines that we have now, that are hopefully going to address how to handle sleep apnea, when to do these sleep studies. But what I would probably say at this point is if you're seeing any type of behavioral change, that's typically the first symptom that we see when it comes to people with Down syndrome. It's not typically a symptom that's related to whatever the problem is, but it's a behavioral change.
We just had another question come through, but I want to make sure, do you have time, Dr. Goodwin, or?
I have time, yes.
Okay.
I'm here as long as y'all need.
Okay. Well, if any of you need to get off, feel free to do so. We are recording this. But we do have, so she says, you talked about self-talking. My daughter self-talks a lot, but recently it has increased. When does self-talking behaviors become a concern?
I love this question. In general, self-talking is a concern for other people, not really for your daughter, is how I would answer that real quickly. But I love self-talk, and I'm going to tell you why. It is I mean, I have teenagers, so my teenagers never talk to me. I never know what's going on in their lives. And so the fact that you have this insight with self-talk is huge, right? It gives you sort of a little peek into what's going on in their lives. So a lot of times you'll hear them kind of going through a conversation, maybe back and forth, and you can kind of listen in and get an idea of what they're talking about and what conflict or whatever it is that they're trying to work out and get through. When I think self-talk is a concern when you start hearing concerning topics. If your daughter starts having self-talk about don't touch me there, or there's some anger, then I think it's important to really start to hone in on what it is she's talking about, who she's talking to, and come up with those questions and start that discussion. So I usually ask people when I'm asking them about self-talk has it changed? Is there a more negative or aggressive tone, or are there any kind of worrisome signs that we need to sort of dig in a little bit deeper and figure out what's happening? And then the other comment I would make would be that I think it's important, because the outside community views this as sort of abnormal or bad or weird, to have that conversation about where self-talk should take place. In the privacy of your room is the best place to go when you want to have a conversation with yourself or work things out. I think that's important to explain to them. Because, they will. My son, we'll be out in the community. We were just at a football game this last week, and, he's busy talking to his imaginary friends as we're walking to the car. And, you get turned heads sometimes when that happens. So I think, knowing where to do it, having a private place to do it, and then kind of paying attention to the tone and what's being said. Those are sort of things I think that need to be addressed when it comes to self-talk. But overall, I think self-talk it's a wonderful thing for us to get information from our children. And I think it can be helpful for them when they're bored and they need to entertain themselves sometimes, and when they need to work through things.
Absolutely. All right. Do we have any other questions? Dr. Goodwin, I do know sorry, I'll say real quick. I noticed that somebody had asked about if you would be comfortable sharing your slides with us.
Sure. I'll email it to you.
Okay, perfect. Yeah, if you'll email them to me, I'll email them out.
Okay.
Somebody was about to say something. Sorry, I cut you off.
You're good. No, it was me, Leah. You touched back on one of the slides about, basically after what happens, like when I get old and my brother's still around and he gets old, and how do we approach that with them? Is there a way to approach it with them so that they can kind of understand? Like, I know my brother grasps the concept that everyone gets old and people pass away, but like, if unfortunately I were to pass before, him, and we have no one left to take care of him, like, are those conversations we need to have with him, or do we need to have conversations with him of, hey, you're going to live with sister until we get old and sit on the front porch with our coffee? Like, do we just kind of leave it, what do we talk about? I guess is my question. I don't know.
So I think that talking about death with an individual with Down syndrome is incredibly challenging.
Yeah.
That's because they are very concrete thinkers. And so we have to use concrete ways to sort of describe that to them if we're going to. And we have to be very, very careful, because here's the other thing. If we start talking about it too soon, then they start to think they're going to die.
Yeah.
And they can start to perseverate about something that's not even really that big of a concern. So I think we have to be really, really careful. I hope I'm remembering this correctly. There's a guide, and I think it's called Jenny's Diary. And it's all about an individual with Down syndrome, it might be more about like developing Alzheimer's and how to have that conversation with an individual with Down syndrome who's developing Alzheimer's. But I think it also, if I'm remembering correctly, it includes some end of life discussions and has some really good examples of the words to use and kind of how to talk about that. The National Task Group is another resource, I think, that may have some additional information on when and how to have these types of conversations, because they really focus most of their work on sort of end of life planning and care and
Okay.
taking care of people with Alzheimer's and dementia.
Okay, that's good. That makes sense because I mean, I'll say, my brother had surgery like recently, and it was like, my mom had surgery a few months ago, and then he had surgery, and I think because my grandmother passed away last summer, it all kind of hit him and was like, oh crap, like it almost was like he seemed something could happen to them and like they could die in the immediate future. So I get that, and I don't want to scare him and have that freak him out when he doesn't need it, but yeah, I'll do some research on that. Thank you.
Welcome. Yeah, that's a tough one. When my dad died and I had to have that conversation with Patrick, I didn't do it very well. So I don't want to tell you what I did. I don't think it worked very well, but it is very difficult. I tried to be very concrete about my words, but the concept is very difficult. Difficult for us to understand, right? Like,
Yeah,
we don't really understand it either. So it's even that much more challenging for them.
I appreciate it.
Okay, we had another question roll in. At what age should testicular cancer screening start?
I mean, typically the pediatricians are doing it, routinely through, but for me, it starts at age 18 when they walk into my clinic. Every male that walks into my clinic, if he hasn't had a testicular exam, he's getting one that day. It's an easy test. It takes 5 seconds, it's something that I encourage families to, there should be some self exams going on, just like women do, self breast exams. And that's the most common way of finding a problem. It should be the same for all males, really. But yeah, it should be done every year. I mean, I have a family who came to me who her son is missing a testicle and she didn't know. So I knew that either the exam was being done and she was never told, but that was kind of surprising for both of us in the exam room. But it's slightly more common in Down syndrome. So it's an easy test to do. It doesn't require any needles or any, imaging. It's just a clinical exam. And so I recommend it pretty much every year of their life.
And just a follow-up. So at home, what would you recommend if we're, screening our younger kids, or when we teach them how to screen for themselves, what are some things that we should be looking out for?
I think the easiest thing to do is to do it in the shower, because they're already, disrobed and they're already kind of, messing around in there with and cleaning up that area. But basically it's just the testicles are they're not completely round. They're more oval, but they're very smooth and soft as you kind of palpate through the testicle all the way around. And so if you feel a bump or a lump, that's certainly something that needs to be evaluated. And the good news is testicular cancer is one of the more treatable cancers. So if we find it, it's usually very easy to treat and get through it pretty quickly. It's not as scary as some of the other cancers, but lumps and bumps in the testicle, and the testicles are the balls that sit under the penis, just to clarify. But yeah.
Perfect. Okay. Are there any other last minute questions? Okay. Well, Dr. Goodwin, thank you so much for joining us today. I know we have lots of thank yous in the chat, and everything you shared is just, it's so good to know. And it's nice that you have that, you know, it's something you really focus in on and learn about so that you can share that knowledge with others. And we really appreciate that. And then, yeah, if you want to send me the slides, I can send those out to all who attended today. That way they can kind of look back through them and, you know, process the information a second time. But yeah, we really appreciate your time and that you were willing to share your knowledge with us. So
Absolutely. Thanks for having me. I appreciate it.
yes.
Thank
All
you.
right. Yes,
Right
and
on.
thank you all for attending as well.
Thank
All
you.
right,
Have a
we'll see you
good
guys
day.
next time.
All right. Bye.
Bye.